I'm Rami Ahmed. I'm a second year co-op student at Conestoga College, Bachelor of Health Information Science. So I'd like to talk today about mostly about the HIM, how it's progressed through years, and is there a real competition between the healthcare and healthcare information management, or we have to collaborate? So I think we have to build a future opportunity. So my big idea here is thinking about the revolution of the data needed is a huge. So, and requires collaboration of, as I said, healthcare providers and the health information management professional. This is to have the best quality of healthcare we need to be delivered for all Canadians. I'm talking about Canada. So this is the milestone key timeline. If you see here, there's the year progress. So we will start from early last century, the start, then we will see how it went through the years till what we have in this century, then what's happening today and future in a small details, I'm not going into that. So first of 1992, the AMA, the American Medical Association, and the American Hospital Association, both, they realized that improved documentation quality is required for accountability of the physician. So the beginning was with the physicians mainly. Then, 1928, here comes Canada's rule in patient records. So there was a team, Canadian, American, patient records, both in Canadian, American, and Boston, October 1928. Leaders working with patient records met and established the Association of Arlana, which is Association of Record Librarian of North America. Usually the medical record was called before librarian, if you remember that. So then at 1942, Librarian of Canada started their own association. So we had, in 1942, we have our first Canadian Association of Medical Record Librarian, and it was established, and they give an acronym for them, CAMARAL. Then they get from the federal government a document that they have been a chartered organization. So as we said, federally they get a chartered organization so they can have a mission and goals to provide membership services. I just have this funny thing, without patent law, inventions wouldn't exist. So the next step was getting a college status. So this is how you see it's going near the CHIMA thing. So they applied for the college in 1960s, and they got it, and they do it to brand credential and to identify the unique skills that needed for the health record professional. And the second charter happened in '72. We had the Canadian College of Health Record Administration, so they are now separate. They are not association and called at the same time. So, and they have become like its own corporate, and they got the letter patent. These are funny comic I see. Somehow your medical records got faxed to a complete stranger. He has no idea what's wrong with you either. And here, I'm afraid we have lost all your records, but the focus group we consulted was 40–80% in favor of you being pregnant. So then, like in 1976, later that, in the 70s, we got the amalgamation again, getting back again. So the Canadian Association of Medical Record and the college, they amalgamated, and so instead of being the judge and serving like some services, they become who's leading everything for the profession in Canada. So they became Canadian Health Record Association CHARA, and was the big thing. Then there's some new concept came out in the 80s where I feel like it's the most time that everything went quick in progress. So DRGs were, it's a diagnosis related groups. As we know, it's introduced to connect financially clinical systems to ensure claims payment. We see this guy. Can you read between the lines? Yes, that's how I feel about medical billing and coding test. And this one is looking for ICD-10. His grandma got run over by her reindeer. So it's like, this is, I think, when we started the medical record making more concept to have what we have nowadays and important how to have our data. Then we got introduced in the 90s for the Master Patient Index. It's a new concept to us at that time. It's to make a unique identifier for a patient and to connect all his records through this masterpiece of our master index. We are reaching near the 2000 where the expansion happened. So the need of and use of health information has expanded in the early this century, and rebranding was initiated to reflect and communicate the enhanced role of the HIM professional and in healthcare sector. So also we have something that impacted our rule, or this rule, is the enhancing technology has a big impact on the profession. So if we think about the technology, think about the paper record before. We were like looking for the physician. It's illegible handwriting. It's a chicken, it scratches. Oh, we need illegible handwriting. Then, no, we have an unapproved abbreviation. No, we need an approved abbreviation list. Now, we're looking for structured data and non-structured data because we have computers and we need everything automated. So this is the way, if you think how it's progressed, the HIM profession. It's like, it's the main concept, but it's coming, the technology changing how it's going on. Then we come for 2003 when the CHIMA came, so the rebranding. The CHARA was the association after amalgamation, now became the Canadian Health Information Management Association. The CHIMA is famous, and it's the college and association at the same time. There is a new strategy has been implemented, and advancing the association was their priorities. In marketing, they were representing HM unique skill sets because they have a unique skill sets. It's not like you cannot find it in all healthcare provider. If you think the healthcare provider, they don't care about the data, how they write it or how they input it in the system. They only just want to write their note and that's it. But there's a unique skill sets. We have to market this about the HIM rule in the healthcare. And now, there's a national rule for the CHIMA, so they are positioning the members as a key players in the quality healthcare in Canada, which is important for us. Then, we have, so it's represent all professionals across Canada, as we said, the CHIMA. This is currently happened. And the changing and the transition happened, it's not only the name of the logo, it's also the profession title as well changed with expanding the rules. So if you see how it's going up, our professions and the rule we are doing, how it's supported in the healthcare. Then today, I'll talk today about some of the rules of the HIM in healthcare. So general task, we can contribute to healthcare delivery, manage health information service, of course working with patient health records, use technology to work with data, analyze data for financial and management planning, interact with healthcare providers and their management. Where we can work. Health records, HR, Rob. Rob, he doesn't like HR. He thinks it's human resources. Then in that mission, quality management, research, information system, decision support, government agency, community health, insurance, nursing home. There's some extra specialty you can do and get a certificate for that. Research, management, quality improvement, risk analysis, clinical trials, clinical financial resource integration. What's in the future? As the volume of the data grows with the healthcare expansion, the next urgent demand in healthcare setting will be integration and harmonizing the data to make it available for support and to enable access of this data to all users that they need it. And this is how we will be prepared for the future to have a better quality of healthcare for all Canadians. Okay, this is a brief on education and certification, how you get certified. It's only, I just mainly, the education part is, I focus on Ontario only. So like we have the diplomas, we have couples of programs you can get a HIM diploma. The degree is only, the degree you can get in Ontario is from Conestoga. Then there's an HIM program in Ryerson. It's only you have to be like have an previous education and you get some courses, then you be certified. Most of those are certified by the CCHM, which is part of the CHIMA. So you can get certified after that if you complete the national certification exam. There's some distance education, McMaster, healthcare, CAN, CHA learning partnership with Algonquin College, and there's some specialty credential programs like you can. This is mainly for health records, the coding and documentation. One of them here in London and the other one in Ottawa. As I said before, certification to be graduate of any of those certified accredited CCHIM program, and then you have to complete the national certification examination, as most of you. Thank you. If you have any questions, I'm here to answer any questions, and that's it. Thank you. Thank you. No questions?
Okay, are you going to write the exam and be certified?
Yeah.
I'd be curious, so Darlene and Dee, I don't know if you guys, were you involved with health records coding before CHIMA?
Yeah.
It came on board? So from
Before it was CHIMA, yeah.
Yeah. So from a coder perspective, did all of the administrative changes reflect big changes in your roles and work?
No, it changed our title. And at first they were going to make us Canadian Health Information Management Professionals, which makes us chimps.
That's really funny.
Like, I don't know how much.
Done?
Yeah.
I saw it already, but I'm sorry.
Can I start from the beginning?
But other than the dues doubling, our professional fees every year have doubled from what they were.
Yeah.
I don't see any.
Nothing really. There's a little more communication, but like.
And now we're a designated profession, so when you do the census, it's one of the professions you can pick.
Are you guys chimps or chimas, or what's your designation?
Chim.
Chim? Because I remember it was chimp.
Yeah, it was.
Yeah,
That's
Deanne was saying.
their think tank came up with that.
It's the college. It's called CHIM.
Yeah.
Okay.
Yes, so when they had the first webinar to announce our new title, I spoke up and said, "You made us chimps." And they're like, Oh, no. It's like when they did the Canadian, what was it, the Conservative Reform Alliance Party, and they were crap. It's like, you have all these people around a table thinking this up, and you didn't see that?
So our instructor, Justin Samways, our coordinator, when he taught us the course for HIM1, he always said, "Oh, don't say CHAM, it's bad, it's bad." So it's not CHAM, it's CHIM.
Professional.
So
I've been calling them chimas, like cheetahs.
yeah.
You know, chimas.
That's better.
You touched on a little bit on the future, but where do you see the play of technology in this space? Because as you alluded to, like data volumes are increasing because we're having more patients and more devices producing all this information. So how do you see technology enabling this type of role going forward?
The first thing we have to think about the structured data and unstructured data. So because of the technology, we want some structured data, coded data, like combo box, drop list, drop down list, checkbox, and combo box. So I see with the technology, it will be easy for us as we see how we manage to use computers, data servers. In this way, it will be much faster, less mistakes. You don't have to make, you can give some algorithm to make the analysis. And instead of the human factor, sometimes I think different than you. So sometimes we don't think it the same way. So, but if we give like a schema or algorithm to the computer, they can deal with the huge data in a short time, very accurately, and we can give them the algorithm, the feed, how we want the input, how we want to get the input and take the output from there.
Thank you.
Remy, I know years ago they were talking about the coding actual work, you know, where you sit there, you read a chart, you find the most responsible, you put in all your other diagnosis.
Yeah.
Is that, I don't know, is it coming to be more computerized now? Are they thought, you know, they'd be reading when they put in the procedure, let's say, because it goes in a computer, it's going to automatically be assigning codes, and then maybe you'd need an eyeball to check and make sure that's correct.
So, as my knowledge, this and our health information management too, we learned about the manual one, and there's the automated one. The automated one, it's only, sometimes it's read the script, it's a free text. It's very hard to take the free text and just make, oh, this is the most responsible diagnosis or that. No, so the automated thing is, it takes the diagnosis, the keywords, and give you the code, but it doesn't give you if it's the most diagnostic, if it's secondary, if it's that. So there will still be a manual.
So the coding is going to be manual for a while.
Yeah, because it's very difficult unless it's structured. Like there's a form and it's a structured data, and they use from a drop-down list, and there's a associated code with this. It will be very hard. This is like I was working in the stroke registry. They want they want us to pull out a lot of things from the Cerner or the data warehouse. It's impossible. It's most of them are reports, free text. It's very hard to get this.
And I can, that's part of my degree and stuff. I've been dealing with natural language processing and all that. And you're right. Like it's very much an active research space. Like I've seen papers where they're trying to apply technology to predict patient mortality, and the rates are, you know, it's good compared to nothing, but on the same note, there's still a fair stretch. So there's still a far way to go before it's going to actually remove the human element. You're right, it's more going to help enable a bit, but you still need that person, that domain expertise, that human to sometimes make those choices.
Like
at least for the foreseeable future.
Yeah. For example, a patient has a primary site of cancer in the breast, and then it's metastatic to the brain, and then he's coming for a procedure for the brain, which is it's a secondary cancer, but in this case, it's the most responsible diagnosis. So how the system you can, oh, it's a secondary, but how the system will know this is the primary thing?
So they have to get there yet. I know when they switched and became CHIMA from being CHRA, they almost killed the profession because they were talking about everything is going to be automated. This is not a profession that has a future. So that's why there was such a deficit of people who had the skill set. And also to be a proficient inpatient coding, especially in a tertiary care hospital. Because if anybody goes south in our outline, where do they send them? Here. So they're very, people who can do the job and do it well are quite a specialized skill set. So I was wondering if they'd come anywhere with the sort of, they were talking about even when they were dictating notes that they'd have a drop-down menu where they would be putting in the MRDX, which would...
Even dictating, I think when I see you I see some projects with the YouTube, and I saw it with some cell phone companies. Sometimes the pronunciation or the accent doesn't make you get the right word. I see, I understand that this is the word the person wants to say, but it doesn't come in the right spelling, so you cannot use that. Also, it's not that accurate. This is why the Google, they're making they want to learn your voice, so to make sure how you pronounce the words, the letters, so they can make more database for your voice, how you say the A, the E, the
That's what they say that 30 years from now will be there.
Well,
or less.
We have self-driving cars. We can teach a computer to recognize cats in videos.
Yeah.
But it's the amount of data. It's the bane, right? We produce so much data, so we need automated technology to be able to get through it. But on the same note, that technology is what's enabling us. We're using that data to help enable the technology, so it kind of goes both ways. But still, yeah, you're right. It's getting there, but there's still so much more farther we need to go. Supervisory, where you have people adding your notes or commentary or extra information to provide to help guide it during that training as well. But regional dialects, different areas, the way we use words and symbols, it's the challenge. You're right.
There's a book we need to read. AI for BI. So we were talking about his thesis, and he's saying AI, and then we said business intelligence. Then all my social network platforms, they recommend me a book to buy. AI for BI. AI for BI. So everything.
A comes before B, I guess.
Yeah, that's right. So everything's moving to artificial intelligence.
I wonder if emergency visits likely could be done electronically.
Mm-hmm.
Not so much the inpatient part of it, outpatient and emergency visits, but I think it's still a long ways away.
Yeah.
Fundamentally, what you get out of it really determines on what you get put into it, right? Especially with machine learning and all that. And the problem is, a lot of what we're putting in, you look at those reasons for visit, you look at some of the commentary, and it takes a lot more interpretation than these systems are built to handle. Whereas the human brain, especially one that's trained to work in this domain, can handle the nuance, the ambiguity, and decipher the problem there. So that's where it's not there yet. It'll help give some guidance, but it's going to be a while yet, I think. Cool.
But computers are more adaptive and they can learn stuff fast, right? So, say for example, few years ago or 10 years ago, computers couldn't beat the best chess player in the world. Okay, yeah. But today, computers can beat any chess player in the world.
Oh, very much so. And also, we're training them to recognize tumors in radiology exams. But that doesn't necessarily mean we're going to be trusting that. We're still going to be using that to maybe kind of identify ones that are likely, and then have someone basically sign off on it. That trust factor is always going to be the other concern. How much do we trust the computer versus having the trained professional in that domain? So.
The advantage with computers is they can do calculations in lightning speed, which we cannot. We will with our experience.
I have just a small comment. In the healthcare, I don't think so. The human factor would be replaced. Think about a simple thing. A small story. Now, I put my location as a work to Conestoga, so it show me the traffic condition every day. So I know that the Google Maps is learning about how I drive, where I'm going. So beginning this week, it's tell me the time to Claims Pro, which is in our building, blah blah blah. How you can predict for the healthcare? You cannot. You cannot. The clinical judgment will still be there. The human factor will still be there. You cannot replace that in the healthcare. It's impossible to make it The human factor is getting less, but getting less to make it faster. And the things we can make it faster, but there's a lot of things we have.
So one of the things that after I was at that OHA conference, I shared you guys a presentation with you guys, and they're talking about patients or people, us having more say and us putting more data into the system, whether it's my Fitbit or a monitor I wear for something else. And they're not going to rely on the EHR and the health and the abstracts anymore. There's all this other monitoring biomed data that they're going to use. So I think there's other data. I don't think health information management will ever be perfected in an electronic way, but I think that other stuff is going to give more real time, more accurate, personalized medicine type of personal behavior, personalized medicine.
It's the same example of the Google Map thing. It's something that's fixed, like, oh, your heart rate is this. So you have a single number, you can compare it easily. Your blood sugar is this. It's easy to make it, but some complicated things, or analyzing or diagnosing, it will be very difficult. Also in the coding, as I said, when I give the example of a secondary brain tumor and you're going to do a procedure in your brain, it's considered your primary thing you're going for in the hospital. It's the most responsible
And it's
diagnosis.
funny because patients don't think that's what they are.
Yeah.
They're like, me, treat all my stuff.
Even the
Don't
healthcare,
just treat that or treat that.
even the healthcare professional, even like I was a healthcare professional, but a lot of I confess that a lot of colleagues, they don't think about the data in the way we think.
It was fabulous.
Thank